Hello everybody, this is a presentation on VTE risk assessment. It's aimed mainly at junior doctors and any other doctors that undertake VTE risk assessment. It's quite a brief presentation, so I'll take you through it. It's mainly based on NICE guidance NG89, which lays out the recommendations for undertaking VTE risk assessment. The presentation talks you through mechanical and pharmacological thromboprophylaxis. There's a brief section on hospital-acquired thrombosis, and I've also covered a small section on NHS trust performance targets for VTE risk assessment. So the main requirement really with VTE risk assessment is that it's undertaken for all admitted patients, or all hospital admissions should have a VTE risk assessment, and this is for patients aged 16 and above. So all hospital inpatients should have a VTE risk assessment, and the main time critical requirement for this is that it should be undertaken within 14 hours of admission to hospital. So it's good practice that you undertake the VTE risk assessment at the time of admission clerking. So when a patient is clocked in, that's the time to do the VTE risk assessment, and you would do a VTE risk assessment even if there is a bleeding risk. So if you're going to hold off pharmacological prophylaxis for that reason, you would still undertake a VTE risk assessment, but you would conclude in that VTE risk assessment that you're not going to be prescribing thromboprophylaxis. So one should still be undertaking a VTE risk assessment even if you're holding off thromboprophylaxis. At the post-take ward round, that's an opportunity to check that the VTE risk assessment has been done. So if it was missed at the time of admission clerking, one must make it a habit to undertake a check that the VTE risk assessment has been done at the post-take ward round. So this next bit covers how you do your VTE risk assessment, what forms to use. So there is a VTE form on Lorenzo that can be used to complete the VTE risk assessment. And the best way to launch the form is to identify your patient through the inpatient ward list, because that way you are selecting the right encounter for the patient, because otherwise there's a risk of linking your VTE risk assessment to another encounter, for example an outpatient episode, but launching the form through the ward inpatient list ensures that you're linking your risk assessment to the correct patient encounter. So try and get into the habit of doing that to make sure that it's linked to the correct encounter. And again, Lorenzo has a selection of VTE risk assessment forms, because lots of other hospital trusts in the country use Lorenzo for VTE risk assessments, and unfortunately other trusts seem to have their own form. So if you use the wrong form, for example, the form for Sheffield is also on Lorenzo. If you use that one, it wouldn't count as a VTE risk assessment done in this trust. So it's important that you choose the correct form, and the correct form for us is the one that's denoted RWW, as I've said on the presentation here. And the best way to ensure that you're using this is to save this form under your favorites on Lorenzo. So when you open VTE risk assessment, this would open as the default form. So then that way you're using the correct form for VTE risk assessment. And also it's important that you complete the form right up to the end, up to the conclusion section, and then finalize the form, which is a little tick box at the top. So you conclude and you finalize, and that way you make sure that your VTE risk assessment is complete. A VTE risk assessment should be repeated if there is a change in the patient's clinical condition. So for example, in obstetrics, you would do a VTE risk assessment before the patient has had her baby, and then once she's delivered, you would need to repeat a VTE risk assessment. Similarly, if a patient has a bleeding risk, you do a VTE risk assessment at the time of admission, and then you would repeat it again when that bleeding risk has been excluded. So sometimes a VTE risk assessment will need to be repeated during an inpatient admission. And once you've done the VTE risk assessment, you would obviously conclude whether you're going to prescribe any prophylaxis. So if you're thinking of mechanical prophylaxis, you must prescribe mechanical prophylaxis. You prescribe TEDs, you would prescribe your anticoagulation as well. And obviously your prescription should take into account renal function. Is the patient pregnant? What is the patient's weight? Is there a bleeding risk? So your prescription should be based on these factors. And then this is to stress the importance of dosing based on the patient's weight. So all patients having pharmacological prophylaxis must be weighed, and the weight must be recorded on Lorenzo, and based on that weight you would decide on the right dose for thromboprophylaxis, and the VTE guidance does cover the dosage requirements for based on weight. And if thromboprophylaxis is to be continued once the patient is discharged from hospital, what we call extended thromboprophylaxis, this must be mentioned on the patient's discharge communication to the GP as to what the indication is and what the duration is for the recommended extended thromboprophylaxis. Hospital-acquired thrombosis. So the definition for hospital-acquired thrombosis is a VTE that develops during the hospital admission or within 90 days after discharge from hospital. So that's what a hospital-acquired thrombosis is. So we should be regarding all HAT as it's abbreviated as, all HAT cases as potentially preventable. So as a hospital trust, the patient safety team reviews all HAT cases, and if we identify that the HAT was preventable, then we undertake a root cause analysis or an investigation, and duty of candor to the patient applies in this case. So the patient would receive information that the HAT was potentially preventable, and we would share the findings of the investigation with the patient. So analyses of the HAT cases over the last few years at the Hospital Trust shows that the common themes for preventable HAT are either there was no pharmacological prophylaxis prescribed, or there was delay in the commencement of pharmacological prophylaxis. So for example, the patient wasn't commenced on medication at admission, was commenced on it say 2 or 3 days later. So delay can also be a contributory factor. Missed doses, so we have had cases where the doses have been missed on 2 or more occasions. That can be a contributory factor. Or even underdosing, so a patient who is overweight or obese would need a higher dose, not the standard prophylactic dose. So underdosing can be a contributory factor as well. So this slide is about NHS performance contract requirements. So all NHS acute trusts are required to demonstrate that we are undertaking VTE risk assessment within 14 hours of admission in 95% of our patients. So this is a contractual performance target, and it has financial consequences for the trust if we don't meet this target. So it's very important to try and undertake VTE risk assessment in a timely fashion, mainly to prevent hospital-acquired thrombosis, but also because as a trust we want to be living up to these performance targets. Over the last couple of years, unfortunately, the trust hasn't met these targets, so we are undertaking quality improvement projects to improve the figures. So it's really up to all of us medical staff to ensure that we are undertaking VTE risk assessments in a timely fashion. So to summarize, I think the take-home points would be that we should all be undertaking VTE risk assessments at the time of admission clerking to ensure that it's done within 14 hours. And check this at the post-take ward round. Make sure you're choosing the correct patient encounter to ensure that the VTE risk assessment is linked to the correct encounter. Choose the correct form and ensure that the form is completed and finalized for it to count as a completed form. And when you're prescribing the anticoagulation, make sure you're prescribing the correct dose, and also ensure you prescribe the TEDs. Any questions, feel free to email the patient safety team and we'll be happy to get back to you. Thank you.